I preface these next few slides with the challenges, and this is one of the biggest clinical challenges that I'm trying to spend a lot of my sort of teaching, education, and my clinical trial selection on, because this is a huge, huge unmet need, I believe, for breast cancer patients with metastatic disease. So just to show you kind of what the suggested problem is, this is a huge data set that was published, albeit more than 10 years ago, with more than 16,000 patients with brain metastases. And what you can see is that it's actually lung cancer that most commonly goes to the brain if you're looking at from people diagnosed with brain secondaries. But breast cancer is up there as a common site that it goes to. If you then look at over 10,000 patients with breast cancer, in the time that they followed up, that sort of 30 years almost, a quarter of their patients developed metastatic disease. Now, if you get metastatic disease, the incidence of brain mets jumps up to 14%. And remember, this is a very old data set. So you question how many cases did they actually miss. This is more recent data. This is published 4 years ago. This is from the USA. What they did was they looked at it from a population base. So they looked at nearly 250,000 of breast cancers that had been diagnosed in 4 years. The ones that developed metastatic disease are shown in red. And I've split them up into terms of what kind of breast cancer, which is what we talked about before. And one of the things that you'll see is the numbers, the blue bars are the patients who got brain metastases. So they're pretty small, which is kind of encouraging. But if you've got HER2 positive breast cancer, so those are those two, or triple negative breast cancer, at initial diagnosis, so when you first get diagnosed with metastatic breast cancer, 9 to 11.5% of patients will already have brain metastases, which is kind of, already bad. But I'll show you the next slide. Having said that, one of the things they found in this very, very big study was that if you were over the age of 60, if you had other sites of cancer, and if you had triple negative disease, then your risk of dying once you develop brain metastases was statistically significantly higher. Now, you can't control these three factors of when you get metastatic breast cancer involving the brain. This is from British Columbia. Again, it's a bit of an older data set, but they did 15 years of follow-up. So now we're looking at measuring as many patients as you can who ultimately get brain metastases following their breast cancer diagnosis. So the numbers go up dramatically. So at diagnosis, the Canadian data is very similar to the American data. But if you're looking over a 15-year time, looking at what happened to these patients who got metastatic disease, up to 29% of HER2 positive breast cancer patients may get brain involvement, and a quarter of those with triple negative disease can get brain involvement. And even though these numbers are smaller, to say that 11 to 15% of hormone receptor positive metastatic breast cancer get brain metastases, that's a big concern because it involves a lot of patients, because this group are the commonest types of, make up the commonest type of breast cancer. We did a study with a good friend of mine from Sydney a few years ago to look at what the Australian data was. And we looked at about 13 years of patients between our two centres. We had nearly 5,000 patients between our two centres. And although we saw a sort of encouraging 4% incidence of CNS involvement during that period of time, look, the group who constituted more than half of those who get brain metastases are actually the hormone receptor positive HER2 negative ones. And yet, this is the group that we don't really have any clinical trials evaluating how do we stop this, how do we treat this. Many of you will know that a lot of efforts are made for triple negative breast cancers because they have traditionally a slightly worse prognosis. HER2 positive breast cancer also have a reasonably high incidence of getting brain metastases. But because these women are doing so well, there's a lot more efforts to trying to improve brain metastases care for that group of patients, to, I think, the detriment of this group of patients. So what do brain metastases look like? I think that's pretty obvious. This is a scan that shows multiple brain metastases. This is the same patient, same scan, at different cut points of the brain. So huge lesions in the brain. And interestingly, this was picked up because I noticed that she was asking me the same question a few times. And I knew this lady for a long, long time. She had no headaches. She had no stroke-like symptoms. Her vision was fine. Her speech was fine. But she just kept on asking me the same questions a few times, which was just not her. Even her husband didn't notice it. He said, oh, no, she's just being a bit batty. That's what we found. Now, an area that is really under-researched in patients who develop brain metastases are the ones where the cancer may not just be in the brain tissue, but are actually on the surface of the brain. So this patient has what's called leptomeningeal disease. So you can see the brain itself is pretty okay, but see this white stuff on the top there, here? That's cancer on the surface convolution of the brain.
Better or worse?
Worse. I know it seems less than that, but this often causes a lot more symptoms, and it's really hard to treat. Having said that, I do have some patients who have actually been cured, but many, many more have not been and have deteriorated very quickly. So again, it's a huge spectrum of what happens. And again, leptomeningeal disease patients are often excluded from clinical trials. One, because their prognosis is so poor. Two, because it's actually very hard to measure whether the drug you're giving is actually reducing it. I mean, if that reduced by 50%, you can say your drug worked. How can you tell there's a little bit more white or a little bit less white? So unfortunately, women that are found to have leptomeningeal disease, even in a trial that is for patients with brain metastases, are often excluded. And this is really something I hope that we can change in the months and years to come. Now, the really good news. Brain metastases identified in 2002. Fortunately for this patient, found early. And yes, she's got a little bit up here as well. This was removed. Radiation treatment. This is her scan 2 months ago. Cured. So there is hope. Don't think if any one of you or anybody you know has the diagnosis of tumours to the brain that is necessary, that's it. There are situations where proper, aggressive, appropriate treatment can really make a difference in someone's life. So currently, as some of you may know, the major way that we treat brain metastases, if it can't be surgically removed, and it can only generally be surgically removed if there is very few lesions and it's able to be reached by the neurosurgeon. So those are the kind of criteria we're looking at. Or sometimes we have to remove one of the lesions because it's so big, it's going to cause harm to the patient. But generally, the role of treatment is whole brain radiation. And just to give you an idea how many patients require that, there was a very good study published by the Breast Cancer Network from Germany a couple of years ago. They looked at over 1,600 patients with brain metastases from breast cancer. In their study, 10% didn't have any treatment because it was diagnosed at a time where the patient was too unwell. 87% of patients who were treated received whole brain radiation. And if you know or you don't know, but whole brain radiation is very effective, but it can have some very, very unpleasant short-term and long-term side effects. Therefore, the radiation oncology discipline has now developed what's called stereotactic, or there's another modality called cyberknife. And what this is with very complex and clever computerization, they're able to send a beam of radiation to 1, 2, and even sometimes up to 5 or 10 metastases. Now, the Japanese do this a lot, and they're very gung-ho. They'll go up to 10 spots in the brain they'll do. In Australia, it's a little bit less. Often they don't want to offer this if they are just cherry-picking too many, because they basically are not treating the rest of the brain, and they're worried that the patient will then get brain metastases in those parts. The problem with oncologists treating brain metastases is that we don't have drugs, many, that penetrate the barrier, the blood-brain barrier. And this is something that, in our development is part of the makeup that prevents us from having toxins go into the brain. So the blood vessels that are in the brain have a slightly different permeability to other blood vessels in the body. And many of the drugs that we use to treat metastatic disease outside the brain just don't get into the brain. But more importantly, it's really, really hard to do clinical trials because, we've got to have enough patients, they've got to be fit enough. Even with spread of breast cancer to the brain, we need to develop drugs that are based on whether it's a triple-negative breast cancer, a HER2-positive breast cancer, or hormone receptor-positive breast cancer. And we need to know how best to measure effectiveness. Lastly, in many instances, patients will also have cancer in other parts of their body. So we can't just spend all our efforts at trying to treat the brain disease. We have to, at the same time, treat the disease outside the brain as well. And that adds another level of complexity.
Chad, just one question. If you have someone that has metastases in their skull, does that make them more likely?
No. Thanks for asking that question. Because often that's thought, when you're told you've got a skull metastasis, the first thing a woman thinks is, it's going to go into my brain. Fortunately, there's a lot of barriers between your skull bone and your brain. It's got to go through about 3 or 4 different membranes. Now, I do have patients who started off with a lesion in the skull bone and it actually grew into the brain, but it's very, very infrequent that happens. So don't be scared if you're told that there is a lesion in the skull bone because you're not at any particular higher risk of it going into the brain. The higher the risk is basically on the type of breast cancer that you have and where it is and so forth. Now, I just pulled this slide from a talk I gave the other day, so this is not meant for you guys. This was meant for doctors and scientists. But I just wanted to make 2 points. One is the red highlights all the different drugs for HER2-positive breast cancer patients, specifically to help treat brain metastases. So that should be really encouraging. There's been a lot of efforts done, both in the laboratory, by pharmaceutical companies and so forth, to try and develop effective drugs that get into the brain. Part of the problem, though, is that if you look at the green, within each of these published clinical trials, there were different goals of what the doctors were trying to do. So in this first one, and I was involved in this trial, in brief, they were just looking to see whether the cancers shrunk, as they did for this one. And that isn't necessarily all that important. If the cancer shrinks by 5 millimeters, it doesn't necessarily mean that that woman is going to live longer and is going to have less symptoms. The most important trials are where you're looking at progression-free survival. That one, and that one. All right? So it's important and encouraging to know that we actually have 2 trials, one for tucatinib, one for neratinib, that suggests that in those 2 trials where in the HER2 CLIMB trial, 47% of the patients of that 612 had brain disease. So, we were involved in this, so we were really pleased we could offer this trial to our patients. So that's a big, big chunk of patients with brain disease that was actually being part of effective treatment. In the NALA trial, which we weren't involved in because this was just a North American trial, 16% of patients had brain disease, which is still generally higher than most other trials. And they actually found that the patients who received the drug actually lived longer. And that's an important endpoint. Is the drug available in Australia? This one is on a shared care program, about $1,500 per month. This one is being considered for registration, probably won't be available, I would imagine, for another 12 months. Just to give encouragement for women with hormone receptor positive breast cancer and triple negative breast cancer that travels to the brain. We have a number of different drugs that are being evaluated, and at the moment, several of these drugs are thought to penetrate the blood-brain barrier. So it gives some hope that those other 2 groups of patients are going to be, being supported and have effective treatments if they were to develop brain secondaries. So I guess for a community that's very invested into, you want research to be done in the areas where it's helped. Brain disease needs funding, it needs community support, it needs consumer awareness that it's not the end all be all, but it's absolutely an unmet need for metastatic breast cancer. Currently, something in the order of 22% of the patients that I treat will develop brain metastases. And I think, one of the reasons why that, and compared to 20 years ago, it was about 4% of patients had brain metastases, because women with metastatic breast cancer are living longer. They're not, it's not a 2-year survival. We're looking at 5 years, 10 years, 15 years survival. And the longer you live, because you've got your disease controlled in your liver and your lungs and your bones, there's a greater opportunity for brain disease to occur.
I do have a question. One of the things I really appreciate about the consultations with you is that even if things are not working, there's always, but I have this treatment. That's really lovely. So I always come out positive, even though I'm cranky that it didn't work. But after a couple of, this is not working, you still start to wonder, shit, do I have to start making those baby books that have been sitting there for 16 years? Will you give sufficient warning when things are actually, I don't have the whole picture, I don't know what else is out there. Will I get enough warning when you say...
From me, I will, and I will try. Sometimes, in retrospect, you might still say, well, Alan, I would have liked to have known that a month ago. But, it's a balance. I mean, I think all of you who know me for a long time know, the balance is, I want to give you hope if it's realistic hope.
Yeah.
I don't want to take away options if it's an option that you would consider. And sometimes, even if I know you very well, there comes a point in time where you aren't ready to give up options. I'm suggesting to you should consider stopping, but you're saying to me, no, I still feel well enough. Even if I can have a 10% chance of responding, I still want it. Others will say to me, so a 25% chance of it working? Nah, not enough. So as much as possible, and I don't have a crystal ball, I have to use, my experience, I have to use the scans, the blood tests, to know what's happened with your state of health. And that's probably the most important thing, is if you say to me, I just don't feel that well. That is probably the most important information that you can convey to me, that helps me know, okay, we now need to talk about how many realistic options there are and whether not pursuing treatment is a appropriate and reasonable thing to do. I mean, there will be times when patients say to me, and it's after the first, second, third treatment, saying, no, I'm going to give up now. And I actually say to them, no, don't give up, because those 3 treatments you went through have kept you going for 8 years. I know you're feeling sicker now. And yes, the chances that my 4th drug is going to work is lower. But hey, these are the side effects. And you've said to me, you don't mind losing your hair. You just want me to make sure that your bowels work. And this drug is not going to affect your bowels. So for that patient, that's a good option. And I don't want you to miss out on it. Whereas others will say to me, okay, I've had 5 different treatments. I'm still feeling pretty well. You're offering me 3 different options, but, if it's only got a 20% chance of working, and if it's only going to help me live for another 4 to 6 months, 4 to 6 months is not worth it. I'd rather have 2 months without visits to hospital, scans, and that's fine. I would never try to talk that person out of saying, no, don't do that, do this.
Not to excite all of our imaginations, but can you go ahead and give us what the symptoms of brain metastases would be?
It's kind of the same question I get asked when a patient finishes her adjuvant chemotherapy with me, and they've been seeing me every 3 weeks for 6 months. You're not going to see me for 6 months. Why aren't you going to do scans? And I tell them, and they accept it. Okay, give me just a small list of the symptoms I should be looking out for recurrence. I said, my smallest list is 298 symptoms. I'm not going to give you a list.
The
top 6, headache, seizure, a stroke-like, event, droopy face or can't walk or, sometimes it's actually just your family notice you're just a bit off. You haven't falls, you don't have headaches, but you're just not your usual self. Is that enough?
That's only 4.
Okay. Visual disturbances, and probably get a bit unsteady when you're walking. So a bit of a and you keep, not necessarily to one side or the other side, but you just trip a bit. You don't have any weakness in your leg, but you're sort of a bit discoordinated.
That's 6, thank you.
I'm not going to be ordering more MRI brains in the next month. I promise you, all right?